All right. Well, thank you very much for the opportunity to be here. And what I'm going to try and do in the next few minutes is walk you through what I think is, at least in myeloma, one of the most exciting areas of development, and that is the availability of immunotherapy-based approaches and monoclonal antibodies. So here are my disclosures. I work with a number of companies that have agents in development or in, who have been approved in myeloma. And so I want to take you back through sort of a bit of a visual version of how I view the agents that we have in myeloma. And if you go back to the 60s, and these cars are from the 30s and 40s probably, these were the agents that we had initially in the early years of myeloma development. And about a decade ago or so, we began to get really excited when we began to get novel agents, thalidomide, lenalidomide, bortezomib. And we thought those were really cool. But now that you look back on them, while they work pretty well, and some of these cars look pretty cool as well, it's really the new novels that are getting us excited. And at the forefront of the new novels, and these actually I got from my son, so I don't even know what cars these are. But while we look for the new novels, of the new novels, probably the most exciting in terms of a class is the availability of monoclonal antibodies. So as we think about adding in new drug classes for patients with myeloma, I think it's important to realize where we need these agents and how will they offer a significant benefit. So we know that the use of proteasome inhibitors and IMiDs in combination with alkylators and steroids, depending upon whether a patient is younger or older, have improved progression-free survival and overall survival. And in many ways, we've talked about targeting mutations in cancer now. And we know that there are probably only 2 or 3 druggable mutations available in myeloma at any given time. BRAF is one. Whether targeting BRAF in most patients who are BRAF positive helps is a debatable question. IDH1 and IDH2 may be another one. Many of the other druggable targets in myeloma by mutations don't clearly have drugs for us to be able to go after. But the most active drugs we have in myeloma are actually not targeting mutations. They're targeting normal plasma cell biology. Proteasome inhibitors and IMiDs and steroids all target normal plasma cells. And so if you continue on that theme of trying to use the most effective plasma cell-directed therapies, antibodies become high on the list of potential targets. Now, one advantage of antibodies over things that require internalization and signaling is that antibodies represent what I call a risk-agnostic approach to treatment, meaning that its efficacy is not dependent on acquired mutations within signaling that's inside the cell. So you may be able to have activity in high-risk myeloma and low-risk myeloma because you're targeting something on the surface as opposed to being dependent on intracellular apoptotic pathways for the agent to be able to have its efficacy. So what are some of the targets that we have available? And as you can see on this cartoon, there are a number of potential targets that are available, both that have preclinical activity, have in clinical development, which is in blue, or potential targets that are in green here. But I want to focus on probably 3 of these for the course of today, and that's CD138, CD38, and SLAMF7. I think those are the 3 that are probably furthest along in terms of their development. So let's start off talking a little bit about CD138. CD138 is a target that is almost universally expressed on plasma cells. In fact, many of you who work with genomic studies of myeloma know that we CD138 select plasma cells when we do whole genome sequencing. And so CD38 makes a great potential target. The only other sites of presence for CD38 in the body are tonsils, where you can get CD138 expression, the oral mucosa, you can get CD138 expression, and in the skin. But in general, especially in the blood tissue, CD138 is almost exclusively expressed on plasma cells. And while CD138 represents a good target, part of what was done with the BT062 molecule was adding a vinca alkaloid to the back. So it's sort of a Mylotarg, if you will, for myeloma, in the sense that it's a targeted delivery of a chemotherapeutic agent. Now, if you look at the single-agent toxicity and in the phase 1 study, what you can see is the most common side effects were mucositis and hand-foot syndrome. And that hand-foot syndrome was really a skin issue. Patients developed skin rash. It looked like hand-foot, but it was really skin rash in nature. And again, that speaks to the 138 expression in those specific tissues as a potential target for drug conjugate administration. What we did notice in this phase 1 study was that there was not an overwhelming response rate. It was probably less than 15%. I can tell you I did have a patient that had stable disease for almost 2.5 years with refractory myeloma. So it could certainly hold disease at bay, but it was not going to give you significant responses as we saw or will see with other antibodies as we go along. And this represents some of that data in the phase 1 study. Again, MRs, stable disease in 50% of patients, PR in only 1 patient, or 4%. So this was single-agent activity. Now, in preclinical work, there were a number of studies that looked at combining this monoclonal with both bortezomib, which my a priori sense would have been that would have been a great partner because you're using a DNA damaging agent or a VINCA, a chemotherapeutic agent. Combining that with a proteasome inhibitor might give you synergistic DNA damage and cell death. But what was interesting was that by preclinical work, the most potent synergy was actually with an IMiD. And so trials were done combining an IMiD with BT-062. And one of the things that I want you to focus on here is the idea that if you look at patients that were refractory to lenalidomide, there were 12 patients that were refractory. 8 of them actually had a PR or better with the combination of lenalidomide and BT-062. Remember, nobody responds to BT-062 alone. So the idea that you're taking a len-refractory patient population, re-exposing to len, and resensitizing to the combination with this immunoconjugate is really very exciting. And I'll tell you, we've got a number of patients in the phase 2 expansion now who have fit just this bill. Patients with len-resistant disease, you add in len with BT-062 as part of the trial, and they go ahead and respond again. So this, I think, is a really intriguing concept, and it speaks to the notion of an IMiD antibody combination, but perhaps for a completely different reason than what I'm going to show you in subsequent slides with CD38 or targeting SLAMF7 in patients with myeloma. So let's switch gears a little bit and talk about CD38 and heme malignancies. CD38 is not present just on plasma cells. It's actually present on a number of lymphoid subsets and may actually have presence in mantle cell lymphoma, diffuse large B-cell lymphoma, CLL, B and T-cell ALL, and even some subsets of AML express CD38. And what we do know is that prognosis is directly correlated with expression of CD38 in the context of CLL. So while we like to think about CD38 as being a myeloma drug, and most of the preclinical work and clinical work has been done in myeloma, the potential for use of CD38 targeting is actually across many different hematologic cancers based on expression. Now, daratumumab is an IgG kappa monoclonal antibody, and it's important to remember that because we're going to talk about the impact of response assessment in patients who are getting monoclonals in a disease where you're actually looking for antibody production. And that may actually be a challenge to the paradigm in terms of how we define PR, CR, and stringent CR, because we're now adding in a drug that's going to get picked up on an SPEP. And so how do we filter that together with assessing response? And again, if you look at potential mechanisms of action for daratumumab, CDC, ADCC, ADCP, direct induction of apoptosis through interference with signaling, and modulation of enzymatic activities with calcium flux and signaling are all potential mechanisms by which daratumumab is able to induce some level of response. And I think what really struck many of us at ASH and ASCO over the last few years was the waterfall plot from the phase 1 trial. And this was the Gen 501 trial presented by Torben Plesner and other colleagues in Europe and in the US, looking at responses in a phase 1 clinical trial. And what I think is really quite impressive is you're getting near CRs with a phase 1 study of a drug, and many of these patients were very, very heavily pretreated. And this gave us hope that we may be able to progress forward using CD38 as a target as a single agent. And remember, to date, no antibody had shown single agent activity in the context of relapsed and refractory myeloma. Now, one of the things that we began to notice is that there appeared to be a dose effect. And this was a very small trial. You can see N of 20 versus 20 on both sides. But it looked like the 16 mg per kg dosing was better than the 8 mg per kg dosing. And so based on this, a subsequent trial was done looking at 8 versus 16. We hope to see some of that data presented in the near future at larger meetings. So based on that concept, the idea of combining an IMiD with an antibody was developed. And again, much of this is based on the preclinical data that was demonstrated from Ken Anderson's lab, suggesting that IMiDs could enhance NK cell number, T cell number, NK cell function, immune function, and enhance ADCC over the course of treatment for a patient. And that was validated in data that I'm going to show you after this, looking at elotuzumab, where elotuzumab plus lenalidomide clearly demonstrated synergy. And so the idea was, if you begin to do this with daratumumab, could you also see pretty significant activity? And in part of the phase 1, phase 2 study, I'm showing you the waterfall plot, and I love showing waterfall plots whenever there's solid tumor oncologists in the room, because in hematologic malignancies, it always looks so much better than their waterfall plots. You know, we're a little unhappy with an 85% response rate. And as you can see here, a significant fraction of patients had at least a PR, with a large number of patients achieving a CR. And this was the phase 1 portion of the trial again. Pretty much everybody responded to the combination of len plus daratumumab. If you then start to look at other subsets of patients, best overall response, 100 in the phase 1 cohort, 86 in the phase 2 cohort. You then start to look at when the responses occurred. They began to occur relatively quickly. And again, you can see patients could stay on for a long period of time. And I think assessing complete remission in patients who are getting monoclonal antibodies is going to be a little bit more challenging, and we have to know this as we go forward. You can see daratumumab may interfere with immunofixation, and particularly in patients that have an IgG kappa paraprotein, because DARA is an IgG kappa paraprotein. And this is not unique to daratumumab. This is unique to monoclonal antibodies, where the main mechanism of response assessment is SPEP. As you'll recall, in lymphomas and other diseases, we assess response with lymph nodes and CT scans. This is the only disease where we actually use a biomarker like the SPEP. And so when the therapeutic agent interferes with that biomarker, we have to be prepared to either change the response criteria or use alternative methods. And there are alternative methods. An interference assay has been validated now moving forward, where you can actually separate out whether the remaining protein is the monoclonal antibody daratumumab or whether that antibody is persistent disease. And that's something that we can look at going forward. If you look at safety, again, you can see no DLTs were assessed in the first 45 patients, and the main issue was really associated with infusion reactions. For those of you who are used to giving monoclonals like rituximab, like ofatumumab, and all these other antibodies in lymphoma and in CLL and even solid tumors, the frequency of infusion reactions with daratumumab is no different than what you see in many of those other hematologic or solid tumor malignancies with monoclonals. And again, this shows you that most of them occur early on. You don't see much of an issue with subsequent infusions, as patients usually have an issue with if they're going to have an issue, it's with the first dose, not really an issue with subsequent doses after that. Now, what about other combinations with daratumumab? This was a trial that I think is a really interesting model for how to look at clinical trials, and that is one trial that combined multiple agents with daratumumab in multiple arms. And you could argue that the arms were too small, and I'm not going to tell you that I think this is definitive evidence that these are all safe combinations moving forward, but they certainly give you quick pilot data that allows you to then go do larger phase 2 or phase 3 expansions. So this was a 1B study combining daratumumab with either bortezomib dex, VTD, VMP, or pomalidomide and dexamethasone. And remember, most of these patients were newly diagnosed in these three. This was the only relapsed refractory combination in the 1B trial. And if you look at responses, our number of patients, again, you can see almost everybody responded. Not a big surprise, because these cohorts were newly diagnosed myeloma patients. These were relapsed and refractory. You can see in a POM-based population, at least 50% responded. I can tell you that there's additional data in a larger phase 2 expansion that suggests that the response rate is actually quite favorable. Hopefully that data will be reported as well. Again, if you look at the waterfall plot, most patients in the entire 4-arm trial had at least a PR or better. And I think that, again, demonstrates pretty significant efficacy for combining daratumumab with a proteasome inhibitor, and an IMiD, or with a second or third generation IMiD such as pomalidomide. So let's switch to the other anti-CD38 monoclonal antibody, and that's SAR-650984. This binds a different epitope than daratumumab does, and again, there were phase 1 and phase 2 studies that were reported combining, either looking at SAR alone, as we're seeing in this study here, and again, if you look, there appears to be a dose-dependent and schedule-dependent response rate, but again, very impressive response rate of about 30% as a single agent for patients who are getting the SAR antibody with relapsed and refractory myeloma. The better the response, the longer the durability of that response. And again, we've had experience with this antibody at our center. We have a patient that's been on for close to a year now who had, again, coming into the trial, refractory myeloma. But as everybody's doing in the world now, you see single agent activity with an antibody, you want to begin to combine it. And so here we have combination data with SAR-650984 in combination with lenalidomide and dexamethasone. And again, this was a small 31-patient trial. 95% of patients had seen prior len or pom, 85% were refractory and relapsed to either len or pom, and almost all had seen prior bortezomib. And if you begin to look at the response rates here, again, you can see overall response rate of about 60%. Again, a significant amount of patients achieving either VGPR or better. And if you can look here, you can see some of the responses, clinical benefit ratios. Again, very heavily pretreated group of patients. Data suggesting that the combination of an IMiD plus a monoclonal is synergistic. It's not just additive, it's synergistic in terms of overall response rate, likely due to enhanced immune function and enhanced ADCC and other immune-related effects. Now, why did we begin to think about this? And so I've gone forward and shown you some really new data. I'm going to go back a few years to some data that was published by Madhav Dapkar looking at the efficacy of lenalidomide both in normal donors and in patients with myeloma that may explain a lot of that synergy that we see in patients who are getting an IMiD in combination with monoclonal. And what I think you see really nicely is a significant enhancement of activation and number of NK cells, both in myeloma patients and in healthy donors. And one of the important things that I often hear from many immunologists is, well, why are you combining dexamethasone with lenalidomide? That's going to counteract the effects that you see. And if you look at Madhav's data here, dex plus len is actually very active compared to dex alone. And so the idea, just as we know with rituximab that you can give monoclonal antibodies with steroids and it doesn't impact their efficacy, the same I think is true with len-dex. You get probably more enhancement of NK cell function and number when you combine corticosteroids with an IMiD than when you give the IMiD alone, because you make the IMiD better. And so that idea that don't give steroids, you're going to make the immune function worse, that may not necessarily apply when you're using the IMiD for the main focus of enhancing anti-tumor efficacy. So where have we seen the most data in terms of combining an IMiD with a monoclonal antibody? And that is the use of elotuzumab. And elotuzumab targets something called SLAMF7. And for those of you who are confused and think I'm talking about some wrestler on WWF, this is actually the target formerly known as CS1. So CS1 is now was too broad to be really applicable to elotuzumab as a target. SLAMF7 is a much more technically accurate name for it, and it's important for expression and signaling. It actually activates immune function itself through direct activation of NK cell and enhances NK cell mediated ADCC. And what we know about ELO that is different from every other monoclonal that's out there is that ELO is in fact dependent on NK cell mediated ADCC. And so combining it with a drug like len that enhances NK cell number and function was really critical to the success of elotuzumab as a targeting platform. We know that SLAMF7 is highest expressed on plasma cells. It does have low-level expression across other hematopoietic cells. It's not expressed at all on non-hematopoietic, so it's different from CD138. And again, we know that in knockout models that are missing SLAMF7, they do not have normal NK function. And so the importance of SLAMF7 as a target, not just for myeloma, but also immune activation, is really critical to the success of the combination platform as we move forward. So one of the differences about SLAMF7 targeting is that in NK cells, targeting SLAMF7 actually results in activation of NK cells, whereas in myeloma cells, it does not have a significant single-agent effect, but it forms the platform for ADCC that can then come on and hook to that monoclonal as you go forward. And so again, there's a two-pronged effect of targeting SLAMF7. The first is direct activation of NK cells, which then come in and kill myeloma cells. The second is tagging myeloma cells for recognition that then allows NK cells. So it's a dual function, and you probably need a little bit of both to really have optimal cell death as a consequence of elotuzumab administration. Hence, the synergy when you combine with lenalidomide and dexamethasone. Again, a different version to look at this, lenalidomide enhancing adaptive and innate immunity, IL-2 secretion and NK cell activity, combining with a drug that enhances NK cell number and function as well. So, sorry. So based on this concept several years ago, very, very many years ago now, was it 8 or 9 years ago it feels like, we sat in a room, it was 7 years ago, several of us sat in a room in New York actually, not far from here, and designed the trial combining lenalidomide and dexamethasone with elotuzumab. And remember, this was probably 5 of us, 5 myeloma investigators in a room surrounded by about 15 company representatives from a company that doesn't even exist anymore, 2 companies ago for elotuzumab. And basically the company representatives were saying, this antibody has no single agent activity. What are you talking about? And we kept having to bring up the preclinical models and the concepts to say, we really think there's something here, let us do the phase 1. And in the end, the agreement in the phase 1 was you could treat patients for 6 months and then you'd have to stop. Because we didn't know whether it was going to really show anything. And after the first 10 patients that were enrolled, finally the company realized that maybe we should let more than 10 patients get enrolled on the trial, or more than 6 months of therapy as we go on. So again, it eventually led to a randomized phase 2 looking at 10 versus 20 mg per kg of elotuzumab in combination with lenalidomide and low-dose dexamethasone. So if you look at the overall response rate in this phase 2 expansion cohort, 36 and 37 patients were enrolled, 92% response rate versus 76%. Remember, the response rate for Lendex alone in this patient population was about 60 to 65%. If you look at overall response rates here, again, very different than what you'd expect for either Elo alone or for Lendex alone. But while response rates are exciting, what ultimately matters is PFS. And so we started to look at PFS in both the 10 and the 20 milligram cohort. And what I think you can see here in the 10 milligram per kilogram cohort, 33 months was the median PFS that we saw in that. And in the 20 mg per kg, 25 months was the median PFS. Both of those are significantly longer than you'd expect with Lendex, even in the most recent version of the Aspire trial, where Lendex alone was 17 months. So again, this concept of synergy between an IMiD and a monoclonal antibody, regardless of the dose that you used, was clearly superior to what you'd expect for lenalidomide and dexamethasone alone. And again, what we're now waiting for is data on the phase 3 randomized trial of elotuzumab Lendex versus Lendex in the Eloquent 1 trial for newly diagnosed and the Eloquent 2 trial for relapsed and refractory disease. Hopefully we'll hear on this data in the next 6 to 12 months. If you begin to look at treatment-emergent adverse events, one of the things that I think is really quite unique about the monoclonals, and you're going to hear us talking about 2 drugs and 3 drug combinations for newly diagnosed. To me, the question is now 4 drug combinations for young transplant-eligible patients, presuming that 4th drug is an antibody. And why do I say that? Because antibodies, as you can see, have very little in terms of additional adverse events compared to their partner combination drugs alone. The only thing that was really increased with Lendex over Lendex was infusion reactions. And as I mentioned with DARA, this is really only an issue for the first infusion. Once you get past that first infusion, and now with pre-medication strategies we have for ELO, this is almost a non-issue. I won't say it's a non-issue, meaning it never happens. It's rare now with appropriate pre-medication, and patients can get through this. Once they get through the first dose, it's really much less of an issue overall. So again, our conclusions were it's clearly a very active combination, 84% overall response rate. PFS for the 10 mg per kg it's not reached. It's now 33 months in terms of median progression-free survival. And if you look at additional adverse events associated with the addition of a monoclonal, there was really almost nothing there that you saw that you didn't see with Lendex alone, with the exception of infusion reactions in the first few doses of therapy administration. So I think this will now give rise to the first and largest phase 3 done with a monoclonal antibody, Eloquent 2, and again, we're waiting on those results, hope to have them very, very soon. So if you think about antibody treatment with myeloma, each combined with lenalidomide and dexamethasone, you can look at overall response rates here. You can look at progression-free survival, and again, most of it was too short. The BT-062 was too early. The SAR antibody, median was 6.2 months, but a very small study. The DARA combination with Len, too early. Elotuzumab is probably the largest and the longest follow-up that we have in combination with an IMID dexamethasone platform for relapsed and refractory myeloma, and the median PFS in aggregate was about 28 months there. Again, significantly longer than you'd expect to see with Lendex in the context of relapsed and refractory myeloma. So I think these are harbingers of great opportunities and great new opportunities for patients as we go forward. So what are other monoclonal antibodies in development in the future? Well, there are many targets that I didn't spend a lot of time on but are coming fast and furious. The first is PD-1. PD-L1 is also coming in myeloma as well. Probably not significant single-agent activity, but nice combination data with lenalidomide and dexamethasone. CD56, CXCR4 has been targeted. CD74 and ICAM1 are just a few of the targets that are coming. Again, we hope that they have single-agent activity, but if they don't, I think we've now learned that combinations, particularly with IMID agents, will give us significant efficacy and activity in the relapsed and refractory myeloma population, and this will give us multiple new targets to think about as we go forward in designing clinical trials. So what is the future direction of monoclonal antibodies? Well, as they say in the Chicago elections, vote early and vote often. I think monoclonals is going to be exactly the same way. We're going to use multiple monoclonals, hopefully together, in combination trials. We're probably going to use them early. There are many trials looking at monoclonals in the smoldering myeloma setting, as well as induction therapy, maintenance therapy, relapsed refractory therapy. We hope that this becomes sort of the vitamin R for us in myeloma. The concept of sequential or combined antibodies with different epitopes, and I don't mean different CD38, I mean perhaps SLAM-F7 with 38, PD-1 with CD38, or PD-1, PD-L1 with SLAM-F7. These concepts are really exciting, and preclinical models suggest they could be quite active. We now need to validate them as we move forward. And finally, one of the real challenges as we're moving forward, and this is the topic of a debate later on, is the issue of MRD. And once you get to an issue of MRD with normal immune recovery, hopefully in the post-transplant setting, there may be ways to enhance efficacy of monoclonals as single agents or in combinations with IMIDs in the MRD positive setting to try and get patients to what I think ultimately will be a larger cure fraction in the myeloma setting. So with that, I think I can stop, and I don't know if we're doing questions now or not, Paul.